to our Department of Medical Informatics and Clinical Epidemiology Research Conference. I have known her for a number of years, and actually even before I knew her personally, I knew of her by her famous cartoon, which you see on the bottom of the slide to the right. And those of you who have taken my introductory informatics course have seen this cartoon, which was published in the medical journal JAMA in 2012, highlighting some of the challenges that our great informatics applications, namely the electronic health record, have done with the physician with his back, his head hunched over the computer, his back to a child and her family. Anyways, several years later, I got to know Dr. Toll. She actually reached out to me to be part of the scientific program committee for a conference she was putting together called The Patient and the Practitioner in the Age of Technology, Promoting Healing Relationships, and really kind of tried to bring together informatics geeks like us with people who are very concerned about the patient-clinician interaction and so forth. And the first conference actually took place a year before the pandemic in 2019 in Providence, Rhode Island. The conference actually continued through the pandemic. We had a virtual conference, and now we're hopefully having the third iteration back in person later this year. So as I said, her slides, I'll go ahead and post the link in the chat again, are here. So Dr. Toll is a professor of internal medicine and pediatrics at Brown University School of Medicine. And she, in addition to a clinician, is an academic and has really been a leader in this area of trying to maintain patient-physician relationships and interaction in our age of technology that can sometimes undermine that. So she's going to talk about the conference and what we've learned, particularly the virtual one that took place this past year, looking at the issue from a variety of perspectives: patients, practitioners, informaticians, educators, ethicists, and so forth. Academically, Dr. Toll did her undergraduate work at Harvard University and went to medical school at the University of Rochester. And did her residency, a combined residency in internal medicine and pediatrics. So I won't take up any more of her time, and I'm looking forward to hearing her talk and hopefully some dialogue that can take place after she finishes speaking. So go ahead, Betsy.
So thank you so much for this invitation and that warm welcome. It's great to be here from Rhode Island, where we're trying to find warm weather, but haven't quite yet. Next slide, please.
It's not advancing. Oh. Sorry.
Not.
Oh. It's not advancing.
Oh.
Let me try this again.
Is it possible for us to pull up the link in Google in the Drive?
Oh, yeah, that's
Sorry. Share. Okay, from beginning. Can everyone see it?
Yeah, we see the slides.
I am not seeing it now. Hang on a second.
Okay, dedication. Okay, I think I'm up.
I'm sorry. Now I can't see it is the problem. So there we go. Okay. So that is actually not the correct set of slides, but that's fine. We'll proceed with this. Okay.
Okay.
Yes.
Are you able to advance it, Lynn, or are you able?
Yeah, are you seeing it? It's advancing here. It's not advancing on the.
No.
Okay.
I am happy to speak extemporaneously if you like. I'm a big fan of radio, and we can try for a radio
I
conference.
mean, we could try it with my computer. I've got
I will forward it to you, Bill. Do you
I
want-
have it. I
Yeah.
have it. I clicked on the link. Let me just try.
Okay.
So to get started, I know all of us are very distracted by the events in Eastern Europe, and I wanted to dedicate this talk to the brave people of Ukraine. And I've included, one of the things that's very sad about this time is how often Ukraine has been in the throes of this kind of despotism. And I included a picture of my own ancestors who fled from Kyiv in 1906 before the Tsar's armies came.
Are the slides advancing for you all?
Yes, they are.
Okay, great.
Only problem is I can't see them.
Really? Not in the WebEx window?
I am in the WebEx window. So here we go. Okay, great. I can see it now.
Okay.
So next slide, please. Next slide, please. So I do have some disclosures about salary support I received from the Physicians Foundation and those who've helped to fund the conference. Next slide, please. So our objectives today are to share learning from a 2020-2021 virtual conference series, as Dr. Hirsch mentioned, that I hope will help you be able to describe some new paradigms of clinical care that use HIT to support patient-practitioner relationships, to state some specific interventions that can improve HIT access for underserved and marginalized populations, and explain principles that increase the success of human-centered design. And finally, some specific steps that we can take to protect patient privacy in the age of big data. But first, some background. Next slide, please. I first became interested in this subject on September 14th, 2009, which was the day that my university clinic converted to the electronic health record. Before that date, I would have told you I have a people job, but after that date, I would have said I had a computer job. It was as though a bomb had fallen into our professional lives. Next slide, please. Pretty soon, I was like Dr. Jones, getting up at 6:30 in the morning to pre-round on my patients, seeing patients across the day, taking a brief break at dinner, and then back on the computer at night until bedtime, completing 24 visits, 16 hours on the computer, and more than 2,500 clicks. Next slide, please. Pretty soon, our research, and could you please go through the animations on this? Pretty soon, our research showed that face-to-face time with patients and computer time were in a ratio of 1 hour face-to-face for every 2 hours of computer time. Much of this was after hours in our pajamas, so-called pajama time. Next slide, please. Continue, please, until the pajamas. Thank you. Next slide, please. It was hard not to notice the same thing in human relationships at work. Whereas we used to talk to our colleagues directly, now we were ping-ponging messages through the computer. And our trainees were spending far more time glued to their computers than they were at the bedsides of their patients. Next, please. I felt I was living in a Greek myth. Would it be Sisyphus rolling up the rock of documentation every day, only to have it roll back down with the frustration that most of what I was writing was for billing and administration, not clinical care? Or would it be the Hydra cutting one message off of my electronic inbox only to find 9 more had appeared? Next, please. Before the EHR, I would have said that in a room with a patient, my brain and my heart were both connected to the patient in front of me. Next, please. But afterwards, I felt like I was in a constant tug of war, with my brain and heart wanting to be connected with my patient, but an alternative loop going into the computer, orders, referrals, prescriptions, and so forth. It was, next please, it was almost as though I was computering while doctoring, which, like texting while driving, causes increased accidents, decreased attention, and oh, by the way, next please, it's illegal. Next please. About this time, my husband came home from the pediatric clinic where he was working, and he said, you should see the picture that Tom Murphy's little patient drew of him. Now, Tom was one of our best residents ever. He had been in the Navy before he became a pediatric resident, and he'd served on an aircraft carrier as the sole medical officer for 3 years. And then he started all over again as an intern. And he was kind and humble and able and on task. But in this picture, his little patient and her family are sitting at the end of the bed, cheerfully interacting, while Dr. Murphy is totally focused on his computer. Next, please. It was hard not to think of this famous painting of the doctor by Luke Fildes from late 19th century, showing a doctor sitting at the bedside of a dying child, the parents in the background. Next, please. Only Luke Fildes' doctor is paying attention to his patient, while AG's doctor is paying attention to his computer. Next, please. When I saw that picture, I said, there's the problem right there. Even a child can see it. I want to find a way for a lot of people to see this picture. So I reached out to Dr. Murphy and asked if he'd be willing to let me write an essay about this picture, and he graciously agreed. And to make a long story short, The Cost of Technology was published in 2012. Now, for this first-time author, that was super exciting. But what happened next was even more exciting. Next, please. People started writing in. They wrote in from doctors, nurses, mental health professionals, lawyers, all decrying the arrival of the computer in their professional lives and saying that it was stealing their attention away from their patients where they wanted it to be, and their jobs had changed and no longer fit, and they had no idea what to do. It seemed to have really struck a nerve. Now, there were a few dissenters, and one of those next was an Israeli physician named Shmuel Rice, next, please, who had been on the computer for 25 years and loved it. And he wrote to me and he said, it's not the computer, it's that you have to learn how to use it in clinical care. It turned out that Shmuel had a long relationship with Brown University, and he came over periodically to work with his colleagues in family medicine. And we got to know each other and became friends. And he admitted to this longtime dream to have an international conference on the subject of how the computer had affected the relationship between patients and practitioners. Next, please. Next, please. So to make a long story short, next, please. We came together in 2017, not just physicians, but also patients, nurses, mental health professionals, HIT designers, institutional leaders, government officials, educators, and researchers, including Dr. Hirsch representing OHSU and serving on the scientific committee. And one of the big highlights was Tom Murphy coming back, next please, and next please, to talk about what he had learned from his patient and her picture. Next, please. Since then, we published a consensus statement in 2019, and we were working on a live conference in 2020 when the COVID bomb fell. And as the worldwide healthcare system pivoted to telehealth, our conference pivoted to a virtual series. Next, please. The series is online if anybody's interested, free of charge through the CME office at Brown. Next, please. The world into which our COVID-19 bomb fell was very different from the world into which our 2009 EHR bomb had fallen. Next, please. We were way more technologically savvy. We were texting and shopping online and summoning our virtual assistants and FaceTiming our kids. And so when this arrived, we in the medical world, next please, and next please, we're very used to working. For example, here's a medical student working not just off the schedule on the wall, but also for other devices. And next please, her Apple Watch. So we were ready. Next please. So once again, we assembled a group of people from all over the United States with Dr. Hirsch, again, serving on the scientific committee and representing OHSU, and 7 other countries. Again, all kinds of people coming from all kinds of perspectives. Next, please. We looked at 8 themes. And things had changed from our first conference. I would say at the first conference, we spent a lot of time complaining. But we also spent a lot of time listening to folks from around the world, and we learned that people around the world were having a very different experience with their EHRs, where theirs had been designed for clinical care and the American ones had been designed for billing and administration. And we also began to think of solutions. And now by 2021, particularly in the pandemic, solutions were coming fast and furiously. So it was much more of a way of using HIT to support human relationships. And these are our 8 themes, which we're going to look at today. Next, please. So we learned that relationships matter more than ever, and yet they are changing. Next, please. So what happens? What is the patient-practitioner relationship, and why does it matter? So when a practitioner creates time and space and brings curiosity and suspends judgment and offers full attention, that's eye contact, listening, awareness of emotions and nonverbals, and bears witness to and sometimes helps to birth patient stories, and then adds the power of human touch. Next, please, twice. That creates a human connection and trust. Then add to that knowledge and technical skill. Next, please, twice. This offers healing for both and emerges from a kind of improvisation. This patient, this problem, this day. Now, what do we mean by healing for both? So I think if you talk to most people who are healthcare practitioners, they probably did pretty well in school, but there may have been some other areas that were tough. Perhaps they were a little socially awkward or not as attractive or popular or athletic as other people. And yet somewhere deep inside themselves, they had a sense that they knew how to help people or they wanted to learn how to do this. Next, please. It could be as the timeless physician we saw earlier in the painting. Next. Or playing with some kids as a pediatrician, or getting together, next please, or getting together with an elder, next, or serving in an underserved part of the world, next, or being in a high-tech setting like the OR or the interventional radiology suite. But in every sense, it was the feeling of being able to connect with somebody to get them to feel better that gave the practitioner a sense of worth and sense of loving themselves. And that is a kind of healing. So it's bidirectional. Next, please. When I finished my training, it was pretty easy to do that as part of our general work. I would listen to my patient, I would observe and use past medical history, think about this patient, their exam, put my learning together, some common sense, think about the emotions in the room. And I often imagined that I had these threads coming into my brain that were being woven together to help create a plan for my patient. Next. However, when I started practicing it in the early 1990s, and I was trying to do this threads and braid thing, I felt like little drawers were starting to open up in my brain. One was called formularies, and it held information about which drug was covered by which insurance company. And another was called specialists, and it had the names of specialists that were covered by certain insurance companies. There were drawers overflowing with billing codes and information about documentation. And I often felt that patient care was being pushed into a little drawer about the size of a pistachio nut. Next, please. So when the EHR joined this with its complex formularies and windows and clicks, it almost felt like now it was braids and threads and braids and apothecary drawers, and an annex had opened in my brain to manage the EHR, and it was almost impossible to focus on what the day's work was. Exhausting. Next, please. So over the past generation, I think we could say that healthcare in the United States has moved from relationship-based care towards transactional care with the growth of corporate and insurance oversight, administrative and regulatory responsibilities, and the presence of the EHR, including all of its challenges and strengths. This has often left patients feeling disconnected and unattended to, and practitioners feeling moral distress, depersonalization, and burnout. I'm sure some of you have had the experience of being in an office with a practitioner who is paying attention to the computer and not you. Next, please. But we've learned that patients and families, and actually practitioners too, want trusting relationships with their healthcare team and their patients, but they also want HIT. They want access to records. Patient portals help manage chronic conditions. Who wants to take care of a patient without being able to look at old labs or old test results? They want it for communication with the healthcare team and for education. But we all want user-friendly technology like in the rest of our lives, and interoperability and merging the best of old and new. Next, please. So team-based care forms one new paradigm for these kinds of relationships. When we redesign the job descriptions in the office or the OR to maximize people's level of training, and we redesign space so that the team can be co-located again, communicating face-to-face instead of ping-ponging through the computer, this streamlines workflow. And the team members get to know each other well in their routines, and they can work together to manage the inbox, close care gaps like who's missing a mammogram or a colonoscopy, and oversee population health, as all of you folks do. The second person can start the visit, can do the documentation, and can help with after-visit care, and also knows the patient well. This increases satisfaction on everybody's part, decreases that pajama time and burnout. And team-based care has been successfully implemented in training clinics preparing future clinicians. So a patient feels, I have my doctor back, not focused on the computer, focused on me. And I'm glad there's somebody else in the office who also knows me well. The doc says my pajama time is way down, and the nurse or team coordinator feels like she has a much more interesting and fun job. Next, please. COVID-19 has certainly reinforced the importance of relationship skills because it's been so hard to communicate with this dangerous disease, particularly early on, and how important it's been seen that clear, regular communication can take place both within the team and with patients and families who can't be on the scene when patients are hospitalized. We've found how important listening and eye contact are, especially because they're so hard to do with masks and personal protective equipment. We've also had much less physical presence and exam as teams, particularly early on, rushed in and out of patient rooms so they themselves would not get sick. And patients have really missed that. But technology has been a phenomenal bridge, video greater than telephone or text. And all of these are harder if there's not already an existing trusting relationship. Next, please. So we could probably say over the past 20 years that relationships have changed from a dyad of patient and physician, where the doctor has the knowledge, the training, and facilitates the agenda, next, to one in which our patients have become also describing the problem and using their own knowledge and agenda setting skills, next, to a triad of the patient, the doctor, and the computer. And by that, we also mean the healthcare team, the family, the healthcare team, and the EHR, into a triangular configuration where all three are working together for the outcome. Next, please. And now we are moving into a four-way relationship with AI. Next, please. And the hope is that if AI can offer knowledge and decision support, that this can leave room for the practitioner to get back towards the patient, the psychosocial aspects of the visit, and strengthen those relationships. Next, please. So a couple of examples. We heard from Dr. Chris Pierce, who's an informaticist in Melbourne, Australia, who now is launching a dashboard of health factors to 2,000 practices in Australia, where an EHR can predict hospitalization. That actually is a little bit high. It's between 75 and 80% accuracy about whether a patient will end up in the ER in the next month, using things like what conditions does this patient have, what medications are they on, how old are they, how much do they weigh, what's their blood pressure today, what do we know about their psychosocial life and habits. There's also a new cough, a smartphone into which one can cough, which diagnoses pneumonia as accurately, actually pneumonia, croup, and asthma with an accuracy equal to a physician plus an X-ray. And at Stanford, Dr. Nirav Shah shared information about how patients are entering their symptoms into a smartphone app, which is connected to allergens and weather and pollution data, which allows them to avoid high allergen areas, decrease med use, and has given a lot more information about patients with allergies, finding, for example, that headache is a more consistent symptom of people having allergic symptoms, and that pollution causes more allergic symptoms than allergens themselves. They're also using myasthenia gravis patients entering clinical data, taking selfies of their eyes and speaking into the smartphone. And the very subtle changes in muscle strength can be picked up more easily by the smartphone app and the audio app, and help people figure out when a flare is coming. Next, please. Next, we looked at disparities, this second pandemic that has plagued us. Next, please. And we heard about, from a visionary leader, speaking about how to improve society's health. This will require addressing structural racism throughout society and medical institutions, offering equal access to technology, HIT education, and the pandemic has highlighted all of this. Next. The foundation for this is trusting relationships and trusting institutions. Next. And that trust comes from respect and non-judgment, seeing every patient as a unique human being shaped by many forces, every one of which impacts health, and allows us to deliver the best care to each patient. Next. We heard about safety net populations where access to digital devices and broadband is a huge issue. A quarter of our rural and a third of our tribal areas have limited or no internet, as we've seen as kids have tried to engage in online schooling. Language and culture are so important to communication and equity. If you want to deliver good health care, patients need and practitioners need access to qualified interpreters. And everyone needs education about using this technology, patients, families, and proxies, people who like group homes or healthcare providers in the home who need to be able to help get on these systems. Research is another area. As we mentioned before, the smartphone can be used as a research tool, and the All of Us project is now seeking 1 million potential research subjects who actually reflect the diversity of the US population. As you all know, there are many cultural biases in AI algorithms and so forth. Next. People with disabilities were addressed as well. They too deserve quality care and supportive technology. When we design for people with differences, it helps us all. For example, sidewalk cuts help not only someone using a wheelchair, but also someone pushing a stroller or a walker. And when we have multiple access points into HIT systems, people who may have differences, for example, someone with autism and social challenges and sensory issues who prefers portal messaging to phone conversations, has a way to communicate. Next, please. So too in mental health, the move to telehealth has shown that we can decrease barriers to accessing mental health, like access to quality care, transportation, childcare, social anxiety, and stigma. Show rates have improved, and we have the same or improved clinical outcomes. One researcher who is working on a project of using mindfulness interventions to treat patients who are pregnant with hypertension found that it was much more convenient for her study subjects to participate in phone surveys, and in fact, she was able to recruit a more diverse group of participants. Next, please. So too in the developing world, well-designed EHRs can improve healthcare delivery. If you have an easy, intuitive EHR, it can be used by a community health worker, a medical assistant, a nurse, not just physicians, and many people can become involved in keeping track of HIV or tuberculosis patients. Innovation can also bring HIT to underserved communities by adding it to existing platforms like banking or rideshare apps. Next, please. Next, we looked at designing human-centered HIT. Naturally, Steve Jobs was not at our conference, but wouldn't we all like HIT that worked as smoothly as Apple technology? Next, please. But it's a challenge. Cumbersome EHR and HIT design plus burdensome work expectations keep patients from practitioners. Next, please. We talked about usability and heard from a cancer patient who is also a digital designer. There is Jay on the left at Sloan Kettering Memorial in New York, doing his 14 laps around the nursing station every day. He has his unicorn horn and his unicorn slippers that his daughters gave him. And as he was trying to get some exercise during his hospitalization, he was just dumbfounded by how much time nurses and doctors were spending at their computers and how little time they were actually spending with their patients. So he developed a tool called UX to streamline usability, involving all users and stakeholders. He found that patients and nurses have lots of fantastic input as well as docs and should be compensated for this. Came up with 8 categories and 42 measures to actually evaluate a piece of HIT. Next, please. Next, we heard from some human factors engineers about the basic principles of human-centered design. Again, we need to involve all users at every stage so we can understand the context and the purpose of a device or a piece of software. And we go through cycles of invention, trial, and modification. And we always need to consider and monitor for unintended consequences, which I gather is this topic of special interest in your department. Again, universal design helps all users. Next, please. Next, we looked at advancing patient empowerment to use this kind of technology, whether that's at home in a healthcare visit or online, say, using chatbots. Next, please. We heard from Liz Salmi, who is, again, a cancer patient who's become very involved in the HIT world, and she advocates for full participation in the healthcare team and has become closely allied with the Open Notes Project to allow patients to access their actual clinical notes, not simply visit summaries. And she advocates for accessing all data and medical records. They belong to the patient. And patients should also begin to contribute to the chart with biographies or visit agendas, photos, videos, articles, and so forth. A new project is coming out of the Open Notes undertaking called Our Notes, where physicians and patients are co-creating their notes. She's also using HIT to connect patients who have similar conditions or experiences through blogging. Next, please. Patients want to create biographies. Wouldn't it be great if you open the chart and you hear what the patient wants to know about you, who you live with, how you like to be treated, what makes you happy? Next, please. And wouldn't it be great if patients could just tell you some information they want you to know the minute you log on to their charts about their boyfriends or their habits, what you can tell their parents? Next, please. Our transgender youth are constantly frustrated by having to re-explain themselves every time they encounter the healthcare system and a new practitioner. Wouldn't it be great to have the basic information when you open the chart? Next, please. Or how about an adopted patient who's continuously asked about family medical history when they have no access to that? Next, please. Something as simple as mirrored screens can help where a patient sees the same thing as a physician, can again create that triangular relationship where patient and practitioner have the same information from the computer in front of them. Next, please. We learned about the patient portal, which has just huge potential and some research successes, including decreased time to your kidney transplant if you're on the portal, prompt electronic visits with an endocrinologist if you're on the portal, fewer ED visits for inflammatory bowel disease if you can get to your practitioner, and improved monitoring of cancer drug toxicities. But portal messages need triaging. Most of them do not require a physician's attention, and it's important to acknowledge and compensate care delivered through the portal fairly. Next, please. We talked about devices, whether that's home monitoring of blood pressure and glucose, or prescribing apps like to evaluate sleep or to track exercise or to gather research data, as we heard about. We heard an interesting project using the Apple Watch to help prevent falls in older adults. But again, this information needs filtering for the patient and the practitioner. Most apps are currently unregulated, and of course, data can fall into the wrong hands. Next, please. Next, we looked at teaching HIT to support this kind of relationship-based care that we all want. Next, please. So two of the leaders here are Wei Wei Li and Lolita Al-Qureshi, 2 docs at the University of Chicago who became famous for their human-level mnemonic, where they help to give people concrete skills for best practices of using a computer in a room with a patient. Next, please. They also made a movie on the Doctor Channel about best and worst practices. Next, please. And now they're helping to train patients to use the EHR using cartoons. Next, please. So here we have A, ask to see the screen. Doc, I'm feeling a bit left out here. May I see what you're typing? The doc says, of course, I'm sorry. Let's turn the screen so you can see your list of current medications, creating that triangular configuration. Next, please. B for become involved. It says there, I'm still taking that pain medicine, but that's not true. I'm not taking it anymore. Okay, glad we reviewed those medicines together. We can correct that. Next, please. Or call for attention. Doctor, this part's a bit difficult to discuss. Could we move away from the computer now? Absolutely. Please tell me what's on your mind. Thanks for listening. And they actually studied this. And when patients were instructed with these cartoons that they had the right to ask for these things and could become involved, they felt much more empowered in the visit. And that was also found from the direction of the practitioners when they were studied. Next, please. We heard from Shmuel Rice, who started all this, and his a resident who's working in his small practice of 600 patients in northern Israel. And they are seamlessly moving through technology in their care, not only having patients in the office, but communicating through email, SMS texting, video participation, whether that's bringing a family member into the appointment or having the doc jump into a specialist appointment. They're using telemedicine, for example, to manage COVID patients, and social media to relay information, for example, recall of a medication, new safety information about COVID-19, vaccination information, and also to address misinformation. And recently, Shmuel has started blogging. One of his early blogs was about creating advanced directives for end-of-life care, and he's kind of nervous about how his patients would feel about receiving information like that. But 50 or 60 patients then filled out an advanced directive and sent them back to him. So it was a tremendously effective way to teach about that. Next, please. Of course, educating humanistic digital practitioners, whether we're talking about all the people currently in the workforce or our future trainees, is going to involve many subjects, not only all medical knowledge, but what's etiquette, note writing, communication, population health, research, teaching. How do we use the EHR for all this stuff, as well as the ethical challenges involved? It's a wonderful opportunity for the young and old to teach each other. Got to start early, and you have to engage the C-suite in this. Next, please. And our learners will need to be versatile to match people and tasks with modality. So for this patient of this age with this need, should we be face-to-face? Should we use telehealth? Do we text, blog, portal, apps? And we have to be very careful not to get our practitioners afflicted with the attention deficit disorder of HIT switching. Next, please. And we have to educate our patients to become full team members, whether that's via a cartoon, whether it's teaching them in the office, or whether it's teaching them how best to use telehealth. Next, please. Next, we looked at promoting wellness in clinical care. Certainly was a huge issue before the pandemic and has become almost another epidemic proportions during the pandemic. Next, please. So there's hope. What we've seen is that from rapid change and the epidemic of burnout in the US before COVID-19, we know that excellent healthcare requires a healthy workforce. That's now part of the quadruple aim. And it's also good business practice. You can't run a business where half your employees are burned out. So institutions need to commit to promoting those human relationships that we all need and clinician wellness, to staffing, to creating adequate staffing and systems, to harnessing HIT to support and not interfere with the workforce, and to get ongoing input from the front lines. That's patients and families and all medical professionals. And we need leaders who are strong enough to hold themselves accountable to these goals. Next, please. We asked some broad questions. What are health and wellness anyway? For all the healthcare we deliver, we don't always have much health or wellness. And we heard from a nurse educator in Scotland who's working on a project with his hydrocephalus and spina bifida patients. He's creating a digital dashboard to help patients figure out what are the elements that are involved in them feeling well. Is it a sense of who they live with, what their activities are, their medications, their treatments? What are the components of putting together well-being? How can they create a wellness score and use that to help them work towards positive change? Next, please. And we heard from a nurse educator in the United Kingdom about health in our society and thinking about shifting our current paradigm of reacting to illness to proactively promoting health. How best can we use technology to work towards this goal? And what would a healthy home or school or business or city look like anyway? Next, please. We heard how improving the EHR experience can improve clinician wellness. At the University of Virginia, the IT department has been using Epic data to analyze doctors' workflow and working individually with them to create, to help them with efficiency, decrease their pajama time and their stress. Next, please. And we heard about an interesting project in Rhode Island where every 2 years, all docs in Rhode Island have to fill out an HIT survey under their license number, and that was linked to their actual Epic user data to see which kinds of interventions, which shortcuts in Epic are actually helping and which are driving burnout. Next, please. There's a series of 3 there. 1, 2, 3, 4, 5. Okay. Next, please. Next, please. And we also learned how YouTube video modules can be very effective way to teach EHR skills, just like it teaches you to change your brakes or revarnish a table. Next, please. We also saw how technology can connect people. We heard from a young attending who during his residency became very jaded by the Marine mentality of the teaching approaches in his hospital. And he got involved in podcasting and found that when people were excited about learning and hearing from people who were kind and warm and friendly, it became joyful again. And he went on to create a pediatric podcast as well. Next, please. We saw, and there's a series of pictures here, I think 3 or 4. We saw how technology can decrease loneliness and shame of professional crises like litigation by helping connect people through blogging and podcasting for support and education about how to go through these traumatic experiences. And we also talked about the use of mindfulness to help people in the healthcare system learn to manage overload. And there's a series here as well. MBAT uses senior clinicians, not mindfulness instructors, to teach medical students to use reflection and meditation to manage stress and emotional, technological overload. Next, please, twice. And this, of course, can be delivered in person or remotely. Next, please. We looked at working with governments, institutions, and stakeholders for support in these healing relationships and wise use of human capital. Next, please. And we looked at the subject of telehealth around the world, talking to practitioners all over the United States and also the United Kingdom and the Netherlands. And we learned that the general feeling was that it was safe, convenient, it connected people at the beginning of the pandemic, and the ease regulations around getting onto FaceTime or Skype with your patient made it possible for people to connect easily with familiar platforms when it wasn't possible through the EHR. And it helped people in remote areas or who couldn't get to the office access quality care. Again, it works best when there's already a trusting relationship between the patient and the practitioner. And over time, both groups wanted human live connection. And many decided they would wait for live visits, which of course has led to delayed care and misdiagnosis that we're dealing with now. Everybody agreed that a hybrid system is the future. We need to compensate people who deliver that care fairly. And of course, there are concerns about teledoc companies who don't have relationships with patients coming in for financial gain. Privacy and security are important, not only hacking into the healthcare aspect of it, but we don't want somebody having a telehealth visit while they're driving. We want to make sure their children are safe. And we always need to think, could there be an abuser in the house at the time of a visit? And again, telehealth is useless if it doesn't belong to everyone. We need broadband, digital devices, interpreting, and education for all. Next, please. Finally, we looked at the ethical stewardship of shared data. Next, please. EHRs have generated huge amounts of data, and population health has great potential. But as you all know, bias and inequity exist in informatics, in AI, and there is that paradox of the interconnectivity that we desire makes it more and more concerning that we will lose our privacy. And so we need to consider confidentiality within the exam room, privacy within the hospital system itself, and security as all of this goes into the cloud. And we need to ally with our patients to advocate for their privacy. Patients have a timeless need to confide in their practitioners. So many people come to their doc as the person who knows their family, who knows them, and to whom they tell their deepest, darkest secrets. And groups have unique needs. Teens don't want the parents to know stuff. Parents don't want their kids to know stuff. People with mental illness don't want anybody to know about it, and many others. So we have to protect patients with education about limits. For example, HIPAA doesn't apply to any data that's been downloaded from a computer. The Cures Act of 2021 is helping both to cause more of a problem and to decrease the problem, but we need clarity about how health data are being used within the system, healthcare system, but also as patients load more and more of it into applications on smartphones. And obviously, big tech and privacy, including health records, is under close scrutiny by the United States press and citizenry around the country. Next, please. So when our system converted to Epic in 2015, there was a big hoopla about the very first patient who was born into the system thereafter. I believe his name was Cameron. This is not his picture. But everyone was so excited that Cameron's entire life would be in Epic. And I can tell you that as a primary care physician, I felt sorry for Cameron. And I found myself sort of flashing through his potential lifespan, thinking about the things every patient hopes nobody except their physician will ever hear about. At age 13, it could be embarrassing teen questions. It could be an episode of chlamydia or a period of, heavy substance use. And all of our patients and ourselves have gone through moments like this that have tremendous personal, professional, and political implications. Next, please. If they are outed on social media. And so next, please. I feel very strongly that those people who are creating electronic health records need to find a way to have a dumb, old-fashioned Word document where a patient may be designed like an old-fashioned medical history, where patients and practitioners can put in this private data, which is highly relevant medically, but is nobody else's business and can never be faxed or shared with anybody else. Next, please. And of course, I'm sure you're all familiar with Shoshana Zuboff's book, looking at the money involved in patient data, whether in applications or other settings on the internet. Hugely eye-opening and hugely important to understand how important it is for us to figure out how to regulate this stuff wisely. Next, please. So to summarize, we are involved in the art of medicine. Next, please. Which asks us to come together to give full attention to patients and the laying on of hands. Next, please. And to create those relationships that are so rewarding for both people, for all people who participate in them. Next, please. But at the same time, we are tasked with science. Next, please. Whether that's using the latest technology to learn new ways to communicate with our patients, or next, please, has given us within incredibly short time of effective vaccinations against this COVID-19 bug, antivirals, and other treatments. Next, please. But has also given us the technology to spread fake facts. Next, please. And misinformation and disinformation. So it's our job to sort through all this so that we can bring together the best of both. Next, please. So I thank you, and I'm certainly happy to entertain questions and comments. Can I ask you to go back for a second? If anybody's interested in the link to these 5 programs, they're available through CME at Brown. We are on to, we hope, a live conference next October. And we've just closed our submissions, but if any of you have a project that you would be interested in presenting at this, Dr. Hirsch is on the scientific committee and you can connect with me, and we'd be delighted to welcome you into a really, really fun fold of people. Thank you for your attention and time.
Great, thank you. Yeah, I don't have any special connections, but we are happy to consider other submissions that come in after the deadline. Well, great. Thank you for this talk, which went very well despite the technical limitations. And as one who participated in this process, I think this is a phenomenal summary of the issues that came up in the conference and also the issues that come up in the practice of informatics. So I'm going to just open up the floor. People can either type questions into the chat, or they can unmute themselves and just speak up. And if you do that, to maybe turn on your video so we can see you. So any questions from the audience?
Welcome comments as well.
Yes, comments too. Well, maybe I will kick it off myself. As you know, Betsy, probably about half of the folks in attendance here are individuals who are studying to become informaticians. And hopefully they have found this helpful. Some of them are clinicians, others of them are not. What advice would you give to someone who's studying the technical side of things, the technology, making it work right? What advice would you give them as they're going through their studies to make sure that they remember some of the issues that you've brought up?
Well, one of the wonderful things about everybody trying to do anything in healthcare is that you're also patients. So you have also seen this stuff playing out in full color in your own visits with your own practitioners. So I think it's important to watch how you feel as you're being treated with somebody who's using HIT to support the visit and somebody who's like, their back is to you, they're typing, they're not paying attention to you. So that's one piece of advice. I think the second is also to remember just people who go into healthcare want human relationships. And so we have to really work hard to try to protect and promote those because it's better healthcare. If you're not paying 100% attention to your patient, you miss a lot of subtle clues and the patient doesn't feel paid attention to. And so they won't tell you the real stuff. So that leads to a lot of excessive testing and misdiagnoses and stuff. And the third is, I think, to engage in that cycle of understand the context something's going to be used in, engage all the stakeholders at every stage of the game, compensate them so they're interested in participating, and think about the unintended consequences of things. I saw Dr. Ash's name go by, I believe.
She
Expert
actually
on unintended consequences here. So I can't see the chat, but maybe anyway.
Yeah,
Dr. Hirsch, if you can help
I'll
me with
read the questions from the chat, and she
Sure.
actually has one in the chat. One of the areas that she's become very interested lately in her research is the use of scribes, medical scribes. So her question is, was there any discussion about the use of medical scribes at the conference, and was it in favor or against?
So again, I think we did talk about the scribes at both conferences in 2017 and then again last year. I think the feeling is, again, it has to do with people getting used to working together. So if your scribe falls out of the sky and is working with you, and tomorrow you have a different one, the next day you have a different one, it's very hard to train that person to write effectively. However, I know some people, for example, who are working with a single scribe who happens to be a physician in Mumbai, who's on a smartphone in the physician's pocket, who is a physician listening to this visit and creating a physician type of note, which is highly meaningful and done by the end of the visit. So I think you have everything from an undergraduate college student who wants to go to medical school, who's working, say, at a free clinic and honestly doesn't know medical terminology yet, to a doctor who's moonlighting as a scribe. So I think, again, it's developing a relationship with that person. It's developing a workflow with that person. It's having an understanding of language. You talk about how to organize the visit, how to organize the notes. So I think that's the value of using a team person rather than a scribe, because that team person knows the patient, knows the visit, knows the context, knows the history. So great.
And I'll move on to the next question, and we'll go a few minutes over since we got a little bit of a late start. If people need to leave, they can just drop off. But I want to make sure we answer every question or get every discussion point gets brought up. So from Annette Garner, so timely. I teach in the RN BS program. In the integrative practicum course, we are in the middle of a 2-week discussion, nursing informatics through the lens of telehealth. this presentation would be so useful for our students, affirming ideas they are bringing forward, addressing gaps they are finding in their practice. Thank you. I think that's more of a comment than a question. But if you have any comments about that comment, that would be great.
Yeah, I mean, I think again, it's, it's so interesting because I think, nursing is such a bedside profession. I think even more than physician perhaps is the sense of being with the patient, staying with the patient till they feel better, whatever that means, whether it's emotional, physical, or both. So how do we think about doing that on telehealth? And it's been so fascinating in the mental health world to see so many people pivoting to telehealth because of the dangers of COVID early on, but which is, in a profession that really depends on the relationship, where you don't have benefit of physical exam. You have only the relationship in the room that you create with the patient. And that's such an important part of why people get better in mental health. What does it mean that so much of that has been moved to telehealth? But actually, a lot of people think that patients prefer that. They prefer to talk about their personal problems in their own home. They feel it's easier to be open. So I think it's a hybrid world, and I think we're going to have to figure out which people fit best with which modalities and which settings, and it's still playing out, I guess is how I would say.
And she's...
And we see a lot of the home. Obviously, when you visit a home on telehealth and when your patient visits your home on telehealth, you get a lot of information about each other. Sometimes it could be the ceiling fan, but sometimes it could be, chaos in the home, order in the home, pets, children. You get a feeling for how things are going. And so that's very valuable information in many cases.
Yeah, and I also think that, we talk a lot about physician burnout and how the impact on of the EHR on physicians, but nurses bear just as much, if not more, impact of the EHR, and probably don't have the same attention that they deserve in how the issues that they deal with. They end up putting a ton of information in that no one may ever look at, or just being bogged down with the EHR.
Yeah. Yeah, I mean, I think there's so much hope for virtual assistants and natural language processing. So, why couldn't we ask Siri, hey, Siri, find me the last CBC, and you guys have probably seen that famous movie about Iris, the EHR created by Crico at Harvard, Luke Sato's group, where they actually, you can say, can you get me the patient's last blood count? What's the patient's wife's name, and when was the last colonoscopy? And in real time, the computer participates as a third conversationalist and then creates the note through that. And I think that's probably where we're heading. And we're in this kind of like, I don't know, the glue age of medicine where everything is just so slow and difficult and split up. But I think we have the technology in other parts of our life that if it were used in medicine would make it much easier just to speak through these things and not to be clicking and searching all these different windows.
Yeah, it wasn't too long ago we were talking about, let's get the fax machine out of healthcare. Mm-hmm. So we've somewhat caught up. We've mostly digitized healthcare, but we still don't have the kind of frictionless technology that we have in other areas of our lives. So
yeah,
hopefully that will change, and maybe some of the folks here will be the leaders in that regard. Mm-hmm. Well, good. I don't see any more questions in the chat, and no one's speaking up. So once again, I want to thank you. Maybe someday we'll actually have you out here live in person. But one upside to the pandemic for us has been that we have had a lot more speakers from outside the university, and so it's been great to have you give this talk. And I hope everyone has a great day, and thanks again, Betsy.
Thank you so much for the invitation, and it's been a pleasure meeting you all remotely. Take care. Have a good day.
Thank you.